Welcome to ECTV here in Barcelona. I'm Paul Endala from Hasselt, Belgium, and with me are Reijo Laaksonen from Finland and Winfried Merz from Germany. And we would like to talk about a big prevention project called the Coro Prevention Project. It's a EU-funded project where we want to include 10,000 patients in a personalized prevention program. And let's start a discussion, Reijo. In the program, we select our patients starting from a biomarker score to let's say, select the very high-risk patients and then do the intervention, which will be a nurse-led digital intervention. Why do we need biomarkers to select these patients? Why don't we just apply secondary prevention to everybody?
Thanks, Paul. Thanks for the questions, and thank you for having us here in your talk show today. Of course, it would be ideal to have all the patients included, but as you said, this is an EU program, and we have a restricted funding and also time course, and therefore we need to do something to be more efficient. And one way of doing is to use a risk enrichment protocol, and we are using biomarkers to select the patients at the most risk, highest risk. We're aiming to catch patients with at least 3% annual mortality, which means that the total event rate for our composite endpoint, which includes CV mortality, non-fatal MIs, and heart failure events, would be probably close to 9%. And if we do it that way, I think we can run a shorter period trial with smaller number of randomized patients, so that we can do it with the EU funding, where we have now the possibility to use about 15 million to run the trial. If this would be a pharma trial, maybe the budget would be 3-4 times more, and then we would do it non-focused way. But now we just have to focus on the high-risk patients in order to have enough power to show that the personalized prevention really works.
And so the concept is that you have a nurse-led program where people are followed up over 3 years, and they are seen every 3 or 6 months, and they are supported by an IT tool to help them in changing lifestyle. And so the idea is to improve on the secondary prevention as it is now. We all know that secondary prevention isn't done in the most perfect way. But which biomarkers are you using, and why are you using them? Why did you select them?
Well, it was a sort of a selection process, which we did together with Winfried, pretty much. We selected at the end of the day high-sense TNI, NT-proBNP, cystatin C, and then a ceramide phospholipid-based biomarker. Based on our experience, that is probably the best available combo together, but they're also individually pretty good markers to identify high-risk coronary patients. And we expect that based on biomarker screening, we will recruit or randomize about 15 to 20% of all the screened patients for the intervention. And those 15 to 20% of the patients, I think, will meet the criteria of more than 3% annual CVD mortality.
And what is the improvement regarding classical risk calculation algorithms that we can use now, like the SMART score, for example, or in primary prevention, the SCORE2 algorithms?
Well, Paul, this is, what we are doing is a little bit a different approach, because our experience in practice, general practice, at least in Germany, says that these scores are hardly used outside. So the major hurdle is that often particular features or variables that are needed for the scores are not available, need to be retrieved from the files. There's special IT tools that need to be opened to generate a score. So if I go for educational lectures and ask the people, general practitioners, are you aware of these scores? They say 10% say me, well, yes, I know these scores. And if I then ask who amongst those who know these scores are regularly doing that with their patients, they say, okay, 1 out of 10 patients we are using this. So it's used in 1% of the patients outside, and for that reason, our concept was to generate something that is new, is high quality, is predictive, but is easily doable. And easily doable would be to just collect a laboratory sample, get it analyzed, and get a score or a risk estimate back. So this is something different because we rely on the information of laboratory parameters rather than on the information provided by clinical information, which may sometimes be false or even crude.
So Paul, it's like a user-friendly tick-a-box type of system. You order the test, you get the result back. And in our case, we made it very simple. We have 4 biomarkers, and if 2 of them are sort of out of range, then the patient is considered as high risk. So easy, tick a box, order the test, get the result, high risk patients, and then you go.
So the GP of the future will not take blood pressure or whatever, just order the test and start with that. Well,
I wouldn't go that far, but I'm convinced that the test provides you really reliable information.
Yeah. Of course, this is just a way of saying, obviously we will continue measuring blood pressure, but this is sort of an enriched composition of risk markers that really gives you a better insight in what is the real risk.
Yes, and that's also, the latest guideline also say that these patients with over 3% annual cardiovascular mortality are at very high risk, and they should be treated differently. So this is one way of clearly and simply identifying those patients.
Yeah, but it steps a little bit away of the way risk prediction and treatment has been done in secondary prevention. In primary prevention we use the algorithms, but in secondary prevention, everybody should be treated, that's the concept, and so everybody leaves the hospital with 7 or 8 drugs if you have a small heart attack or whatever. And so your idea would be that in some cases you would treat much more intensely, but in some cases you might even consider a lower treatment threshold. Is that the right concept?
That's probably the consequence of the whole project, because now everything for everybody, I think it's not probably the best way always. And people are of course talking about personalized medicine and so on, but in cardiovascular we don't really have it. But maybe with improved biomarkers for risk identification, stratification, and then there are more treatments to come. So and they are also expensive. So you cannot spend, and put everybody on the newest. But if you have the biomarkers-based selection, for example, then you can probably focus, and then it probably even makes health economic sense.
Yeah. Let's talk more about these specific biomarkers. So some are well known, others are less well known. Is this from an lab perspective something that you can order from your local hospital lab, or do you need very specific ways of analyzing the drug, the biomarker?
Well, at least part of the biomarkers are readily available everywhere. So cystatin C, troponin, NT-proBNP. The ceramides might be a little bit more tricky because they require specialized equipment. But the development in the laboratory within the last decade shows that measurement of such analytes can be made readily available to any, say, mid-size or large hospital laboratory. So that's in the future, I do not see any major hurdles to get that implemented. Of course, it would be a little bit of an additional effort, maybe, but technology is changing. It may be the case that the measurement of ceramides will be moved away from LCMS to other alternative technologies. I think until the conclusion of the trials, we will have much more convenient methods to measure the ceramides than we have it today.
And specifically about these ceramides, because the other markers, we know them, but the ceramides I know it's a kind of lipid, but what is specific to ceramides that makes them very powerful? I've read some of your articles, I see that they are very powerful in predicting risk. What is different from the other biomarkers we're using, and what is it, a ceramide?
So if I start, so ceramides they're fairly powerful bioactive lipids, and the emphasis is in bioactive. The amount is small, a lot smaller than, for example, cholesterol in bloodstream, and they're carried in lipoprotein particles. But they are linking together the inflammation. They're the driving force. They're connecting cytokines, interleukin 6, IL-1 beta together. They are boosting the synthesis of these cytokines. Cytokines are then in turn improving the ceramide synthesis. So they are inflammatory signaling factors, but they are also tightly related to insulin resistance and diabetes and metabolic syndrome. And so they are sort of a very powerful signaling molecules, and they do have very good prognostic. They're also having a good prognostic sort of a power for cardiovascular outcomes if they're used as a test. And then, Winfried, if we compare with the existing tests, so you have maybe more experience about that.
Well, the ceramides, if you look at the ceramides as a risk marker, you will find that in comparison to the three other markers that we are including, that they are non-redundant. So they are showing something, they are indicating something that you would not capture with the other markers. Maybe inflammation, maybe insulin resistance. They provide additional information formally as well as medically, and for that reason I think it is good to include them into future risk stratification algorithms.
Yes, and Paul, in terms of treatments, if you have a patient with high ceramide values, you can lower the ceramide values with statins, with PCSK9 inhibitors, with metformin, many existing drugs, but just recently in ATVP there was a new review basically indicating that the ceramides are actually very potential drug targets also for the future development for atherosclerosis, diabetes. So it could be that they're not only biomarkers, they might also be the next generation targets in the field.
Amazing. And so it's not going to be only secondary prevention, it's also going to be diabetes, metabolic syndrome, etc.
Yes, I know that there are already quite far some small molecules for diabetes treatments ongoing in using ceramide inhibitors. So it is an evolving field.
And of course, the recurring question in if you want to introduce something in the healthcare system is cost. Is it a cost because it's going to be an analysis cost? Do you think it weighs up to the effects you will have on outcomes?
Paul, that's the question which is very often asked. In the Corona Prevention Program, we're working closely together with NICE. And then we have also a health economics expert group from Sheffield, Alan Brennan's group, and we are analyzing the cost effectiveness of the whole program, the PPP, the Personalized Prevention Program, including the biomarkers. But our initial data basically shows that if you use biomarkers to identify high-risk patients and then you do targeted treatments, then in fact the costs is coming from the intervention. at the end of the day. Then it really does not matter whether the biomarker costs 10 or 50 euros or even 100 or 150, because it's like one-time cost. But then it's the intervention, the visits, the treatments, but both need to be efficient. You need to have a good biomarker to stratify for risk, and then your intervention needs to be good to lower the risk.
Yeah.
Then I think it's most likely cost efficient.
There's yet another aspect with regard to costs. At least the three markers, troponin, NT-proBNP, cystatin C, they are quite often already measured in the clinics currently, but the information provided by them is not used systematically. So why not add one reasonably cheap other marker and make use of the information for risk stratification? Because if you are doing it anyway, it would not cause additional costs. And the second aspect is that in general you need to consider expenses on laboratory analysis do not account for more than 2 to 3% of the total healthcare costs. You know that from your cost calculations in the hospital. So it doesn't matter. It has no sizable impact on the overall costs. And the very intriguing aspect is if you have a tool which would allow you to drive the intensity of the treatment individually, I think in the long run you would also have savings at a much higher level of efficacy. So health economic aspects of this project will really be interesting, and they will teach us that it's worthwhile to concentrate intensive therapy to those who are really at high risk, and lower treatment intensity to those where you can be sure that they will not have a recurrent event.
Yeah. So that you would get savings not only by reducing events, but also by more focusing expensive treatments to the ones that really need it. Is this a marker that you would consider in the future as a measure, say, at 25 years of age, to see if you are going to develop a problem in 25 years, like a genetic marker? Or is this something that is really dependent on lifestyle, or what are the determinants of the ceramides?
Yes, I think we have tested ceramides now in different settings, including very young adults, then primary prevention, middle-aged, up to 90-year-old persons from the Helsinki Business Study. And it works as a prognostic marker all over. The levels of ceramides, the circulating levels, I think they are depending on the background genetics, but also diet, exercise. I think exercise is one of the major factors. So I think you can do an assessment very early age, and so you can see where you are, but they are modifiable. So you can modify your lifestyle, or you can start treatments, but I would go with the lifestyle modifications, diet, exercise, stop smoking. Your ceramides most likely going quite nicely down.
So it really sounds like the ideal marker for lifelong preventive therapy, if I understand you well. So maybe to conclude our discussion, so the concept of a co-prevention study is that we are going to select within the population of secondary prevention patients this very high risk group using some known markers and then the newer ceramide markers. And we will see with the intervention if we can not only lower the markers, but also lower the risk of our patients. Is there anything specific you expect from the results of the core prevention trial? You say, okay, this is going to change therapy, we are going to do it in this way?
Yeah, I think, of course, we would like to prove that changing lifestyle in a personalized fashion is efficient, and it's also cost economic. And now, so far we have discussed biomarkers as identifiers of high risk. We are also analyzing some existing databases from existing trials, and we try to find also markers that are specific for different treatments. So because it's not always that the high risk sort of results in best results. It could be that there are specific patient groups within the treated patients that really gain benefits from a certain or given treatment. And that's the other aspect which we have not yet really touched. But then that goes even more personalized, because then that's really personalizing the given treatment. It could be even a selection of different statin species to a different patients.
So a lot of new information will be coming on from this study. I would say thank you, Winfried and Reo, for this interesting discussion, and I wish you all the success with the core prevention trial.